to today's Postcom seminar. Today we have Dr. Roland Schaette, who's a lecturer from UCL Ear Institute. And Roland has a particular interest in the causes, prevention and treatment of tinnitus. And he uses a really powerful combination of modeling, animal studies and human studies. And Roland has a very interesting background, as he comes from a background in applied physics. Is that
Biophysics.
Biophysics, right. And he has a PhD from Humboldt University in Berlin. His PhD was on the topic of modeling models of tinnitus.
Yes.
And so he's been working on tinnitus since 2003. And since 2008, he's the British Tinnitus Association Senior Research Associate.
And actually the very latest change in my status has been in November. I've been made lecturer for tinnitus research. So
fantastic.
Yeah.
Okay. Oh, we're really looking forward to your talk today.
Yeah. Thanks, Piers, for the introduction. Thanks for having me here. It's a great pleasure always to come to Manchester. And well, today I'm going to tell you a bit about my work on the mechanisms of tinnitus. And I'm not going to talk only about my work, but also about what other people have been doing. And the core topic of the whole lecture is going to be how is tinnitus actually manifesting itself in the brain, what's going on in the brain of someone who has tinnitus, and also then why does it happen? So how and why do we have tinnitus? And so I probably do not need to introduce tinnitus to you, but I'm going to do it nevertheless. So probably all of you have heard a bit of tinnitus already, that after exposing yourself to some loud sound at a nightclub, for example, or going to a gig, you had a beeping in the ear, and hopefully it went away after a few minutes and then never came back. So beeping is only one of the sounds that you can have at a tinnitus. That would be called a tone-like tinnitus. It can also be some kind of a hissing or whooshing or roaring. So there's a variety of descriptions that people give for how their tinnitus sounds like, but it's usually simple sounds. So that also distinguishes tinnitus from proper auditory hallucinations where people are hearing voices or music. So it's just very simple sounds, nothing kind of speech-like or complex about them. And it can be perceived in one ear, in both ears, in the head. In one study, we even had someone who said it's just outside my head, kind of right behind the right mastoid. So it seems to be a bit of an individual thing where the location of the tinnitus is. And it's a really frequent phenomenon. And the estimates for the prevalence vary by how people define tinnitus. If you just ask the question, have you ever had beeping in your ear, maybe the prevalence would be something like 95% or so. But if you ask for chronic tinnitus, so people who have got it constantly and hear it at least every time it gets quiet or very reliably, it's about 5 to 10% of the population who have got it. But having tinnitus does not automatically mean suffering from tinnitus. If you restrict your group to those who actually are troubled by the tinnitus, who really suffer from the tinnitus, it's about 1 to 2% of the population. Those are the ones that then often also have sleep difficulties, depression, and really experience a strong reduction in their quality of life through the tinnitus. And those are, of course, the ones that we do research for, because they're the ones who will profit most from new treatments. Those who are not overly bothered by their tinnitus, well, we probably won't touch their tinnitus, and rather leave it that way. But one disclaimer: I'm a basic scientist. I know not too much about actual tinnitus treatment, but I'm not seeing patients. So, okay. So, one distinction that I also need to get out of the way is subjective versus objective tinnitus, because what I'm going to talk about is exclusively subjective tinnitus. Objective tinnitus are the rare cases where the sound is actually caused by a physical source within the body. So it's no external sound, but there's actually something properly generating the sound. For example, it can be a very loud spontaneous otoacoustic emission, or it can be a blood vessel anomaly close to the ear that generates a whooshing sound, or some people then start hearing their own heartbeat. So a pulsatile tinnitus is often an objective tinnitus. And their tinnitus can also be heard by other people. For example, when you take a stethoscope, you do an auscultation of the head, and you can often hear these bruits, these sounds in pulsatile tinnitus. And that's estimated to be about 5% of the tinnitus cases. So, and that's actually also where a surgeon or could often do something about the tinnitus, because if you correct the blood vessel anomaly, the pulsatile tinnitus can go away. The other cases are subjective tinnitus, where there's no physical generator for the acoustic sensation that can be found. And then it's purely subjective. There's no way for an external examiner to hear a sound. So, and this is the huge majority of the cases, and that's what we're trying to understand, because where does this sound out of thin air come from? That's what we would like to know. And most of the research revolves around tinnitus and hearing loss. Firstly, for the very simple reason that most people with tinnitus also have hearing loss, and when the prevalence of hearing loss increases, also the prevalence of tinnitus increases, for example, when people get old. And also, one of the most reliable ways of getting tinnitus is to give yourself a hearing loss, for example, through loud sounds. So hearing loss is a major risk factor for tinnitus. And furthermore, almost everyone with otosclerosis, the estimates are about 80 to 90% perceive tinnitus, so when they've got a conductive hearing loss. And when you induce hearing loss in animals, for example, through noise exposure, you can see signs for tinnitus in these animals as well. And I've just wrote a review about it, so if you want to read more about my thoughts on these issues, go to Hearing Research and download my paper. Sorry, no more shameless plugs here. Okay, let's have a bit of a more detailed look at the relation between tinnitus and hearing loss. And so here in this graph here, we've got the mean audiogram of people who have been exposed to loud sounds in the workplace. And you see that they've got a nice moderate to severe noise-induced hearing loss here in the high frequency range. At low frequencies, the hearing is normal or near normal. And when we have a look at the tinnitus pitch matching results, where they were just asked to choose the one of the audiometer tones that sounded most like their tinnitus, most of them chose either 4 or 6 kilohertz as their tinnitus match. And that's right here in the region of hearing loss. And actually, almost all matches, except these two here, were to the region of hearing loss. So those matched at 2 kilohertz here, they just had a bit more hearing loss, so it was also a frequency where their hearing was impaired. So it seems like there's a very good correspondence between the region that's hearing impaired and where people hear their tinnitus. And so when we want to understand what's going on in the brain and what's generating the tinnitus, I'd like to start with a few basic considerations for what a neural correlate of tinnitus, so the manifestation of tinnitus in the brain, could be in the first place. It's very important to know for this that even in silence, there's a lot of spontaneous neuronal activity going on in the auditory system. If you stick an electrode in the auditory nerve and you record from the auditory nerve fibers, most of them are active. Some of them are even very active, generating 50 or even 100 action potentials per second. But we don't hear that. It's the kind of ongoing background sound activity in our brain. It's almost like that's the sound of silence, or the neural code for silence. And people with tinnitus hear it in silence. So the immediate conclusion from that is that the neural correlate of tinnitus must be some kind of a change in the spontaneous activity in the auditory system, because everything we hear, we see, we perceive, in the end is neural activity. All we experience is just neurons in our brain being active in a certain way. And what we know from physiology is that if we present a sound, that this changes neuronal activity, and it firstly increases the activity of the neurons that are tuned to the sound, and it also makes neurons be active in a more synchronized fashion. So when multiple neurons are activated by the same sound, they're activated together. So again, a simple conclusion: the neural correlate of tinnitus must have something to do with either an increase in spontaneous activity or an increase in the synchrony of spontaneous activity, or both. So keep that in mind for the rest of the lecture. further considerations, most people with tinnitus can say it's got a certain pitch. So, and they can often choose some tones, or at least a range of tones that sound quite similar to the tinnitus. And the auditory system is organized in a tonotopic fashion. So when there's at some point of a neural structure, there are neurons that like low frequencies, at the other end there are neurons that like high frequencies, and the arrangement is orderly. And when a tinnitus sounds like a tone, it might be that it's some neurons that are tuned to a certain narrow frequency range might just have increased their spontaneous activity. So that this could then give rise to a tone like tinnitus with a certain pitch. Okay, enough about these musings. Let's have a look at how tinnitus could be emerging through hearing loss. So from a lot of physiological studies, we know that hearing loss has consequences in the central auditory system. So it's not only about damage to the periphery, but there are also subsequent changes in the brain. And a very consistent finding is that if you have a look at how different centers of the auditory system react to input, or how they process information, you see that there's a reduction in inhibition. So neurons are more likely to excite each other and less likely to inhibit each other after hearing loss. And one immediate thing that comes to mind is that when neurons are released from inhibition, they might become more active spontaneously because they're just less held back by inhibition. So that could be one of the mechanisms for tinnitus. And then also, when people map the brain after hearing loss, they see a reorganization of the tonotopic map. And it's usually a consequence of high-frequency hearing loss, that then the high-frequency regions of the brain get reorganized. I'll go into more detail of that in a minute. So this could cause altered or possibly more synchronized patterns of spontaneous activity. So let's have a look at this tonotopic map reorganization. So, sorry for the convoluted slide. Here on the left we've got the results from a study where the location of different, the representation of different frequencies was mapped along the auditory cortex of an animal. So at the one edge here we've got low frequencies, and then it progresses towards high frequencies. And here on the right is an animal that has got noise-induced hearing loss, and you see that there's a change in the representation. You get an expanded representation of the low frequencies, and actually no more neurons that are tuned to the very high frequencies. And so it could be that when we have a look here, that those neurons here in the high frequency range that are deprived of input from after the hearing loss couple themselves to the low frequency neurons and thus become sensitive to the low frequencies. And there has been a study in 1998 where they suggested that this could also play a role in tinnitus because they believed to have measured cortical map reorganization using magnetoencephalography, and that's one of their pictures here. The bottom one here being a normal subject, a control subject with an orderly progression of frequencies, and the top here being a tinnitus subject where the 6 kilohertz, which was said to be close to the tinnitus frequency of that subject, was deviating from this orderly arrangement. But there has been a recent fMRI study saying, well, we don't see it if we look at it with a better imaging method. So the jury is still out on that one, if actually tonotopic reorganization is really involved in tinnitus in humans. So far we've got n equals 1 for each, saying yes and no. There have been a lot of studies using MEG to assess the spontaneous activity in the human brain of people with tinnitus. And what they then did, MEG is actually not very good for localizing neural activity. You can only get a rough picture, focus roughly on certain brain regions as a whole. But what you can do is you get a very good temporal resolution. So you can have a look at the neural activity and see what kind of oscillation frequencies occur there. And that's what they've done here. They've done a power analysis of the spontaneous neural activity and graphed that according to frequency. And the dashed line, sorry for the poor graph, but that's just what the paper was, is normal controls. And you see a big difference to the solid line, which is the tinnitus group, in that very low frequencies, you've got a lot more power in the tinnitus group here, and at slightly higher frequencies here, that's called the alpha frequency range, and that here's the delta frequency range, you see a reduction in the power. And this alpha frequency range is thought to be kind of the idle mode of the brain doing nothing. And so the reduction here was interpreted as that the auditory part of the brain are more busy, they are less idle in the tinnitus group. The flaw of this study was that the tinnitus group had hearing loss, the control group had not. So that's a very often occurring thing that you get your interesting group in, and you just need some control, so you just get your students in the machine as well, and have a look, and then they're often not properly matched. So a later study from Nottingham tried to remedy that by looking at 4 different groups, at people with tinnitus with hearing loss, at people who had tinnitus but clinically normal hearing, people who had no tinnitus with hearing loss, and no tinnitus with clinically normal hearing. And when you look at this graph closely, it's unfortunately also a very convoluted graph. You see that the tinnitus groups here in red and cyan show a similar pattern of an increase at low frequencies and a slight decrease in the higher frequencies. So an increase in the delta frequency range and a decrease in the alpha frequency range. So in MEG measurements, it seems like that this is kind of part of the neural signature of tinnitus in the human brain. So, but the problem is, there we've got a very broad picture that what you see in MEG is the coordinated activity of millions of neurons, or at least hundreds of thousands of neurons. And what we, or maybe I, would actually like to understand is how's the processing of single neurons or of small populations of neurons changed, what's exactly going on at a cellular level. So not how the whole thing gets into a different oscillating mode, but what actually, which mechanism in nerve cells is causing that. Because if you want to target anything, you need to know what's going on in the nerve cells themselves, because then we know what, for example, what drug to give or what other treatment we could try. And animal studies have addressed this, and I think I'm already a lot behind time. Anyway, and they looked for neural correlates of tinnitus, and the general approach in an animal study is that you use a procedure that's known to cause tinnitus in humans. For example, you give them ototoxic drugs, high doses of salicylate are very reliable for inducing tinnitus, at least for as long as until the drug gets metabolized, or they used acoustic trauma. And then they use behavioral testing to look for tinnitus. And in the animals, they can then measure the spontaneous neuronal activity and look for changes. And so you might ask, but how can you test whether an animal has tinnitus? So it's only indirect, you have to use behavioral testing. And what they do is they exploit the startle reflex, because if you play a loud sound, an animal jumps, but if you play the loud sound in a continuous background, the animal still jumps. But if you introduce a small gap here in the background sound, the animal gets a bit of a warning cue and it doesn't jump. It's like if someone goes to you and says boo, you jump, but if you hear the footsteps before, you know that someone is coming, you don't jump. But now the trick is to systematically vary the background sound and use different frequencies, and if one is similar to the tinnitus, a gap might be less prominent because the tinnitus is filling the gap, and you see less inhibition of the reflex, so the animal might have a tinnitus of that frequency. And that's now kind of a standard protocol that's used in animal studies. I think I'll just skip that one and go to focus on one specific putative neural correlate of tinnitus, increase in spontaneous activity, because that's what most labs have been using, and they have looked all along the auditory pathway for changes in spontaneous activity after hearing loss, and they found it in the auditory cortex, in the inferior colliculus, so in the midbrain, also in the dorsal and ventral cochlear nucleus, down in the brainstem. And interestingly, when they looked in the auditory nerve, there were decreased spontaneous firing rates of auditory nerve fibers after noise-induced hearing loss. So it seems like there's something going on you don't find anything that looks like tinnitus in the auditory nerve, but you do when you look in the central auditory system. So something must be changing there. And also one of the conclusions is that tinnitus is not generated in the ear, except then we see it in the auditory nerve in that case. So here's a more detailed result from one of these studies. What you see here is a result of recordings from hundreds of neurons, and each dot here is one neuron with a certain characteristic frequency and a certain spontaneous activity. And the overlay here is the hearing threshold measurement of the animal. And here on the right we've got the running average of the spontaneous rate of those neurons. So, and you see that it really nicely tracks the hearing threshold curve. So in the region where the animal has lost the good hearing ability, the spontaneous activity goes up. So there seems to be a really good correspondence between an increase in hearing threshold and an increase in the spontaneous activity in the brain. But and such neuronal hyperactivity, as has been called, is correlated with cochlear damage hearing loss, as you've just seen. It's correlated to decreases in inhibition in the brain, and it's also correlated to behavioral signs for tinnitus. So it's a very nice candidate for a manifestation of tinnitus in the brain. But what has actually not been completely clarified yet is the actual functional mechanism. Why is there a decrease in inhibition, for example, in the brain after hearing loss? And that's where actually my work on tinnitus started. So we wanted to know how the whole process could be, and the very simple line of reasoning that we were following is that cochlear damage leads to altered auditory nerve activity, and we get some kind of plasticity in the central auditory system, and that might lead to tinnitus. And what we were trying to home in on was what kind of plasticity, and plasticity for what reason. And that's what we did in computer models, because there we could evaluate a lot of scenarios, a lot of what-if questions, and see what might be happening. And here's the cartoon version of the computer model. On the top we've got an audiogram that represents the cochlear and auditory nerve stage of the model. In the bottom here we've got two readouts, one for mean activity and one for spontaneous activity of our highly simplified central auditory system stage of the model. And in the middle you see these volume control knobs that represent the gain of the neurons in our model, basically how much excitation and how much inhibition they get. And in the healthy situation here we've plugged in a perfect audiogram, all threshold at 0 decibels, your pristine ear that has never been exposed to loud noise. And at the bottom here we've got a certain normal level of mean activity and a certain normal level of spontaneous activity. And now we have a look at the situation after hearing loss. Here now that's a typical noise-induced loss here from one of the subjects of our other study. And when we now have a look here in the high frequency range, we've got an increase in the hearing thresholds of about 60 decibels. That means all the soft sounds are no longer heard in that frequency range. And if you just calculate with certain assumptions for the acoustic environment what that means for activity in the brain, we get a huge reduction in the mean activity. It's simply all those auditory nerve fibers in the high frequency range are no longer activated, and all the neurons more downstream also don't get any excitatory input anymore from them. And also, modeled on the physiology, the spontaneous activity is also decreased, which goes back to a reduction of spontaneous activity of the auditory nerve. Now comes the one big liberty we took in the model, because such a decrease in mean activity could be a strong signal, a strong activator for plasticity. And there's actually one plasticity mechanism that cares about the mean activity, and it's been called homeostatic plasticity, because from what is known about this mechanism is that it's stabilizing the mean activity of neurons. And it's been shown that if you reduce activity artificially in neurons in a dish, I must say, they scale up the strength of the excitatory synapses and reduce the strength of inhibitory synapses, and also get more excitable. And if you artificially increase their activity, the changes go in the opposite direction. So it seems like an adjustment of the neuronal gain is happening there to get activity to a certain target level. And we just assume that this might be happening down in the auditory brainstem, and used our model to see what might be happening. And the simple consequence is then that here in the high frequency range, the gain gets increased to increase the mean activity again, to bring it back up to the target level. And when we've increased the gain sufficiently to get the mean activity to the target level, and we have a look at the spontaneous activity, we see that it's come at a price. Because now the neurons have become so excitable and so responsive to input that they started amplifying the spontaneous activity, so-called, so to say, the neuronal noise. They're now amplifying any input, so they're making a lot of activity out of very little. And you see that here now, in the high frequency range, we have an increase in spontaneous activity above the normal level that was there before. And very simply, if we now say, okay, what if we say this peak here is our tinnitus frequency, we can then compare to patient data and compare the predicted tinnitus pitch to the actual observed measured patient tinnitus pitch. And here's what we get. The gray bars, that's the distribution of patient tinnitus pitch, and the red bars is our full model. If we switch off the homeostatic plasticity, our prediction immediately shifts to lower frequencies and it's no longer consistent with the results. And here's a scatter plot showing that there's also a reasonable correlation between the results from the model, the predictions, and the actual pitch. And whereas if we switch off the plasticity, it's completely way off. So that's a very, very easy scenario to explain how by just the brain trying to compensate for hearing loss, tinnitus could emerge as a side effect. But there's certain problems with that. For example, about 10 to 20% of people with tinnitus have a clinically normal audiogram. So the question is, what's wrong with them? Do they have tinnitus for a different reason? Or is the model wrong? Or is there a different thing we've completely overlooked? So if we have a look at these two mean audiograms here of a group, the black line is a group of women, mean age in their 30s with tinnitus, the gray line is without tinnitus. And if we have a look at the results of the tinnitus characterization, where most of them shows the high frequency tones here as most similar to their tinnitus, as really no hearing loss here that could explain why they've got tinnitus according to the standard model. So as we liked the model very much, we decided to investigate if maybe we had overlooked something and decided to have a more detailed look for signs of cochlear damage, and we measured their auditory brainstem responses. That's a very simple way of measuring evoked potentials. Probably most of you have done it already at least sometime. You just put 3 electrodes on the head, one on the high forehead and one behind each mastoid, and you start presenting sounds to one ear, and then you measure electrical activity generated by the first stages of the auditory pathway. And the really nice thing about the auditory brainstem response is that you get this succession of waves here in the response, and each of the waves corresponds to a different stage of the auditory system responding. So for example, wave 1 here is the auditory nerve close to the cochlea, and wave 5, another very reliable wave here, is generated just below the inferior colliculus. So we've got a peripheral and a centrally generated signal in here. And so we then just had a look for what were the differences between our two groups. So for wave 1, we found a significant reduction in amplitude of wave 1 for the tinnitus and between tinnitus and control group. So the tinnitus group had significantly smaller amplitudes at both the levels that we tested, 90 and 100 decibels. And then in contrast to that, wave 5 was not significantly different. It was almost the same levels here between the two groups, which first of all was reassuring. We could have also just been that we completely messed up the measurement of the tinnitus group and just got small amplitudes that way. But that didn't seem to be the case. So now our task was to understand what was going on there, and for wave 1, for the reduction in amplitude, we could turn to a study that had been done shortly before in mice, in 2009, because they used a noise exposure at about nightclub level on the mice. And here's what it did to their hearing. This is here now about threshold shift, so how much hearing threshold of the mice has changed. And one day after the noise exposure, they had a huge hearing threshold shift, about 40 decibels in the high frequency range. And then over time it recovered. After 3 days it was already quite a bit less, and after 2 weeks it was back to normal. This is also well documented for humans. If you were to set up with your audiometer in front of a nightclub and measure people's hearing before and afterwards, they'd have a hearing threshold shift afterwards. And it usually recovers over a few hours or days. The thing is, in the mice, they also did not only have a look at the thresholds, they also had a look at the amplitudes of, again, wave 1 of the auditory brainstem response. And here it gets interesting. So in green, we've got the control mice, which show a nice growth of the amplitude of the ABR signal with sound level. In red, it's 1 day after the exposure. So you see that here we've got this threshold shift. It takes a lot higher intensities to evoke a response at all, and then response start to grow. And then here we are after recovery, where you get a response also for similar low intensities, but then the growth is a lot flatter here. It kind of almost plateaus here and then only grows a lot less. So it never catches up with the normal amplitudes. So there's a huge reduction in the amplitude of ABR wave 1 at high sound intensities. Very similar to what we've seen in the tinnitus group.
Sorry to disturb you. The fire alarm will be going off in about 5 or 10 minutes. It's just a test, it's nothing to worry about.
But we'll all have tinnitus at the end of it.
Yeah. Okay. So, as these were mice, they could then have a close look in their inner ears to see what was actually causing this. And but they did histology of the inner ear and used immunohistochemistry to have a look at different structures here. And what you see here is a normal mouse, and the green labeling here is auditory nerve fibers. So all these spaghetti here are auditory nerve fibers. And in red here, you've got the cell bodies, the nuclei of the inner hair cells, and the tiny red dots are the synaptic ribbons. So this is part of the contact between hair cell and auditory nerve fiber. It becomes clearer here in the schematic picture. Here you've got one inner hair cell, you've got the hairs on top, and here you've got the nucleus. And here at the bottom, the auditory nerve fibers contact the cell, and opposite each auditory nerve fiber terminal, there's one of these synaptic ribbons, which are 5 minutes. Oh dear. Okay, so when you have a look at the noise-exposed mouse here, you see that there's a lot fewer of these red dots, so they've lost synaptic ribbons. And what this does is, it means that the contact point here between auditory nerve fiber and hair cell becomes non-functional. So it's almost like unplugging the auditory nerve fiber. This can immediately explain why there's a reduction in amplitude of ABR wave 1, just because there's fewer auditory nerve fibers contributing to the signal. And for wave 5, well, given our train of thought from the model, a very easy explanation is that it might have to do something with gain. So because if you assume that in the healthy case there's a normal sized wave 1 as the input signal to the central auditory system, and then you get a normal sized wave 5 out with a certain low gain. And if you put in a smaller wave 1 and get a normal sized wave 5, one easy way to get that would be to increase the gain. And that's actually, yeah, I'll skip that here to come to the model again. That's actually how it works very easily in the model, because if we adjust the auditory nerve stage of our model to have deafferentation of auditory nerve fibers, we also get a reduction in the mean activity in the central auditory system of our model, just because there's fewer auditory nerve fibers providing input to the brain. And then when we get the increase in gain here, to compensate for that, we get an increase in spontaneous activity again. So it's a very simple scenario with one mechanism for the development of tinnitus that works for both tinnitus with normal hearing loss and tinnitus with clinically normal hearing, but hidden hearing loss, as we've called it. And so the model then suggests that it's it could be some kind of neuronal activity stabilization after hidden hearing loss that could lead to tinnitus in these cases, and that increased neuronal gain in the auditory brain could be caused by decreases in input, and that's actually very well along those lines. And also Kevin is working on in his studies with earplugs and acoustic reflex thresholds. And the tinnitus could then be simply a side effect of an attempt of the brain to compensate for a decrease in auditory nerve input. And as there's one mechanism for tinnitus with and without hearing loss, the relevant change is a decrease in auditory nerve activity. So the conclusion would be that auditory deprivation should be able to cause tinnitus or phantom sounds. And so there has been a classic study done already in the 50s that when you put people in an anechoic chamber and leave them there listening to nothing, that they start hearing phantom sounds. And it's a fairly fast process. It only takes about 10 minutes or so. And that the tinnitus then ceased after leaving the booth. But, well, actually putting someone into an anechoic chamber is really removing all acoustic input. It's a very drastic manipulation. It's almost like deafening them, and or an equivalent to deafening them for the amount of time that they spend in the anechoic chamber. And so to see if a lesser degree of deprivation could also cause some phantom sounds, I've teamed up with Kevin here to basically piggybacking my research interests onto his studies of earplugs. And there were 18 healthy participants in that study. They had all normal hearing, and they wore an earplug in one ear for 7 days. And 14 out of 18, when asked carefully, and in order to not just, asked very carefully, they said that they perceived phantom sound during the time that their ear was plugged. And on day 7, 11 of the 18 participants had a kind of a stable phantom sound, at least when it was quiet enough for them to hear it. And fortunately, well, not really unexpectedly, because Kevin had been doing earplug studies for years, and there had been no one who came to him saying, oh, you've given me a permanent tinnitus. So the sound disappeared after earplug removal. I'll get that as a bonus time afterwards, or? Okay. Well, and there was also a fairly decent correspondence between the attenuation characteristics of the earplug, which worked best for high frequencies, and the frequency characteristics of the tinnitus, so which also turned out to be high frequency. Unfortunately, the measurements of the attenuation of the earplug was a bit limited for high frequencies, so we couldn't really measure for as high as the tinnitus spectrum measurement went. So this can also be very easily recreated in the model if we just put in the attenuation characteristics of the earplug and let the whole algorithm run. It starts increasing the gain to compensate, to get the mean activity up to the target level, creates increased spontaneous activity, and then if we take the earplug out, we still have got the increased gain, even though hearing is back to normal, so we get an overshoot in mean activity. Everything sounds a bit louder at first, and then the model turns down the gain, gets mean activity back down to where it belongs, and in the process also reduces spontaneous activity, and the tinnitus is gone. So this very simple model can account for all these findings, and so it's at least a good illustration of a work in progress hypothesis about what might be happening in tinnitus. So just to briefly wrap up, so the conclusion would be that you might be able to cure tinnitus if you can cure hearing loss. Well, the problem, of course, is that currently we can't cure hearing loss. There's definitely no way of yet of letting hair cells regrow and reconnect to auditory nerve fibers, even though people are working on it. So, and hearing aids have got, they work wonders in some situations, but in other situations they are still less than perfect. But there's one case where it has been quite remarkably demonstrated how effective curing hearing loss might be, and that's otosclerosis. When people have got an otosclerosis and a conductive hearing loss through it, it can often be reduced or even eliminated through surgery. So there you've got a mechanical problem, you can fix it through surgery, and it turns out that these surgeries, stapedectomy or stapedotomy, abolish tinnitus in around 50% of otosclerosis patients. So it's really not just reducing tinnitus, it's abolishing it, apparently. And the majority of the rest get a reduction in tinnitus. So it seems like if you can really improve hearing ability, again, you can decrease or even abolish tinnitus. So, and also the tinnitus reduction was correlated to hearing loss reduction, so it further supporting a causal relation. So one study said that the better the surgery outcome, the more likely they got a decrease in tinnitus. Okay, and then I'm already at the end here, so managed to stay on time, hopefully. So I'd like to thank my colleagues at the Ear Institute, David McAlpine, Paul Radomski, Leon Cox and Thomas Cracknell, two students who helped me on the ABR study. And then there's Charlotte Turtle and Kevin Munro from here to thank. Well, Charlotte has actually moved on, she's now in Cambridge. And then Richard Kempter from Humboldt University, who was my PhD supervisor and with whom I worked on the first version of the model. And the British Tinnitus Association, who has been funding my work at UCL from 2008 till 2013, and just recently UCL has started paying me actually themselves. So, okay, well, and thanks for your attention. We even got time for a few questions.
I think we have time for just a couple, yeah.
Yep. Before we get kicked out by the next lecture.
So, the argument, Roland, is that a hearing loss, even a subtle one that we can't detect with clinical tests, changes the spontaneous firing rate? Or spontaneous activity?
Yeah, it might do so in the brain, yes. Okay. So we've just done a mouse study where we've tried to recreate this and record from the brain, and it seems like we get a substantial increase in spontaneous firing rate in the inferior colliculus after it was exact same 100 dB exposure that didn't really change hearing thresholds, but reduced ABR wave 1 amplitudes.
So my question is, not everyone with hearing loss has tinnitus.
Yeah.
And not everyone with tinnitus has hyperacusis. Mm-hmm. So what are so there's a couple of missing links somewhere.
Oh yes.
What are your thoughts?
Well, the question about why not everyone with tinnitus has got hearing loss has got tinnitus. Well, got a slide for that just for the numbers. So it seems like, at least from one epidemiological study that I could find, the prevalence of hearing loss is about 4 times higher than the prevalence of tinnitus. Other sources say it's more like that at least half of people with hearing loss also have got tinnitus. So that one is maybe a bit high, but still, that's one thing that is very important to understand. What's the difference between those who've got a hearing loss and no tinnitus and those who've got a hearing loss with tinnitus? In one of our studies, we had a bit of an indication here that people with noise-induced hearing loss without tinnitus had, on average, slightly more hearing loss than those with tinnitus, and the slope of the audiogram was a bit less steep in the no tinnitus group, but it was a group effect. It was very hard to say you have tinnitus because you've got a steep slope. The way of distinguishing between them based on these characteristics was not too good. But basically, I think that to understand why not everyone with hearing loss has got tinnitus is one of the most important remaining roadblocks on the way towards a proper cure for tinnitus, because there, in understanding this, there might be some kind of an off switch. There are speculation that, for example, sensory gating at the level of the thalamus might play a role, that those who don't have tinnitus have got an intact gating mechanism, whereas those with tinnitus somehow have a disturbed or impaired gating mechanism, and that therefore some kind of changes that might take place in the brainstem always after hearing loss only lead to tinnitus in those where it can feed through to the cortex, but there's still some work to do to answer that.
I can't see anyone waiting outside, so does anyone have any final questions? Richard, please.
It's, I was just trying to think how tinnitus maskers will fit in with this model, because it could be that instead of actually masking the tinnitus, you're actually causing the gain to change. If that is the case, do you think we might, if you've got single frequencies or tonal tinnitus, you'd be better off targeting the masker to?
Oh, that's a difficult one. Of course, if you could first of all determine the tinnitus frequency reliably enough, then you might have some kind of a minimal masker that's very narrow band around the tinnitus frequency. Problem is that tinnitus pitch matching in itself is a very inexact science. It seems like test-retest reliability seems to be quite low, and also seems to depend on the method. There has been one study where they used 3 different ways of doing tinnitus pitch matching, and then had a look at the results across methods. There was one subject who always chose the same frequency, and on average the range of matches was more than an octave. So that's one caveat that's actually true for a lot of more recently proposed tinnitus treatments that somehow say, okay, we first characterize your tinnitus and then we tailor a stimulus to decrease it most effectively, either by playing a tone at exactly the same frequency, or playing tones around it, or adapting music such that around the tinnitus frequency there's a gap in the music. And there have been quite a few suggestions, but they all have the same problem, that they first need to establish that tinnitus pitch matching can be reliable enough to have the proposed relation between therapeutic stimulus and tinnitus. And also, so about maskers, one other thing that you need to keep in mind when you're using commercially available maskers is that their frequency range is actually not really brilliant. Most of them top out at about 5 to 6 kilohertz, and tinnitus can be quite a lot higher, especially in people who still have good hearing. We had matching results going up to a 16 kilohertz. So
16 or
16, yeah. That was the highest frequency we tested, and then they said it's the one that sounds most similar. So it might be that the very high pitched tinnituses after 10 years, I'm still looking for a decent plural of tinnitus. Any suggestions highly appreciated. That these the very high pitched tinnitus sounds might not be reached by maskers or hearing aids, for example. So I'll have to see.
I mean, my next sort of question sort of follows on from that, was about the identification of the tinnitus frequency for tonal tinnitus. Have you looked at any sort of audiogram fine structure?
No, I haven't.
Because, I mean, for my own tinnitus, I get a nice sort of fairly accurate measurement, which is very repeatable, like about 6.3 kilohertz. But I just wondered whether that's something that you might be missing on the clinical audiograms.
Yeah.
That it may be that actually these subjects are showing something at the tinnitus frequency that's not being picked up.
Yeah. Well, definitely. I mean, from a modeling perspective, I very much would always like to have the audiogram very finely resolved, and to get as much data into the model as possible. It's just the kind of usual constraints of the audiology clinic that can supply with data when you're not measuring yourself, that make the audiogram such a coarse-grained measure. In our own studies, I must admit, we also used a rather coarse-grained frequency step at the same half octaves, because we wanted to do other things with our tinnitus subjects, but and not only measure their audiogram in the high resolution, but ideally, in a perfect world where you have got very dedicated subjects that are happy to come several times, I'd first start with a very good characterization of their audiogram, and then do all other tests and see how things, what is in there, and have a very comprehensive data set for each subject, and then could put it all in the model and understand probably a lot more. But I don't know, maybe I should get a lot of money to hire my subjects permanently as kind of just your job is now to be in my research, and and I'm going to do test after test on you for 2 months, and
Okay.
That'd be
I
good.
think we better finish up there. Yeah. Thanks very
before
much,
I
Roland.
start
Okay.
more things about